in Nigeria, Nigeria for dream, the nation of God, in unity we stand, building a nation in unity. I believe in Nigeria, Nigeria for dream. I believe in Nigeria, Nigeria for dream, the nation of God, in unity we stand.
So I'm Denise Dahm, and I'm part of the Geriatric Fellowship. What we're hoping to do this year with some of the sessions are allow our fellows an opportunity to refine their presentation skills and bring topics of interest to the group. And so this will be a new effort for all of us, so your feedback and suggestions are welcome. We have two forums, or two types of presentations we're hoping to bring. First is what we're having today in M&M, where she, one of our fellows, will review a case with some teaching points and then hopefully generate discussion about diagnosis and management of conditions, with the goal of improving patient safety and quality of care. The second are geriatric core topic-based presentations that the fellows will bring on other Thursday sessions. So Rashidi, thanks for kicking it off. And as I said, we hope that her base presentation will then generate some discussion among the group here. Take it away.
All right, thank you. So this is my M&M. So I'm going to present a case of a lady that I saw this month on the ACE unit. And the ACE unit is an inpatient geriatric unit at Crystal Santa Rosa. So this, she is a 78-year-old woman. She was seen in clinic for hospital discharge. So she was discharged in June for acute MI in Houston. And although the physician that saw her had no discharge summary at the time she was seen, this patient had a left heart cath without any stent placement. And also she reported a possible diagnosis of congestive heart failure. And when she came in, she was taking Corvallo and lisinopril. During the visit, she reported shortness of breath ongoing for a few days, and also edema on her ankles, from her knees down, and also some 5-pound weight gain, she said. And she had been using her albuterol nebulizer every 4 hours to try to relieve her symptoms. So essentially, she was admitted overnight for further evaluation. And the next day, when I saw her, she was complaining of anxiety. She was clenching her chest, complaining of anxiety, severe anxiety, left side of chest pain, and shortness of breath. Any questions regarding my HPI? Any additional questions that you have? Or any additional clarification about the HPI?
How old is the patient?
78.
So she was admitted from the clinic visit?
So she was, yes.
Okay.
So she was sent to the ER from the clinic visit, and then admitted from the ER.
She wasn't prescribed a diuretic?
How old is she?
It wasn't on her medication list, no. So her past medical history is anxiety disorder, asthma, and COPD, and she was in home O2, and also remote history of pulmonary embolism and dementia. And I'm sorry about that. The cognitive score wasn't done when she came to the hospital. Her past surgical history is an appendectomy. She also had a recent surgery also in June. She had an abdominal scar removal and a cauterization of the liver lesion that was benign, and cholecystectomy also in June. So this is her outpatient medication. She was on Coreg, lisinopril, Lipitor, Advair, albuterol, Ativan, Remeron, Miralax, multivitamin, and calcium. Family history includes dementia in her mother, heart failure in her dad, dementia also in the sister, and osteoarthritis in her sister. And she was widowed. She had moved to Texas in 2012 and was living, she was not living with her daughter, and it was mostly because of her severe anxiety while she was living with her daughter. She was independent in all her ADLs, but needed some assistance in some IADLs. She was a former smoker but denied illicit drug use on her own intake, and she was DNR. On review of systems, she reported shortness of breath and also reported leg swelling also. And her vitals when she was seen, blood pressure was 148/76, pulse of 74, and she was satting 94% and 2 liters of major calorie. And her weight was 43.99 on that day. The day she came, which was June 30th. Her last clinic visit on 5/22, she was 39.46 kilograms. And when I saw her, she was sitting in bed, like I said, clenched in the middle of her chest, and she appeared to be very distressed. Actually, the nurses told me that she kept back and forth asking for her Ativan. On exam, nothing significant on her CV exam. On her neck exam, she didn't have any GBD or carotid bruit, and nothing significant on her CV exam. On her lung exam, she had bilateral breast sounds that were diminished. Abdominal exam was also nothing significant except for surgical scars from her surgery back in June. And on exam, she was alert oriented to name and place only. Her cranial nerves were intact, and nothing major on her motor exam.
Okay, G, what you, does anybody have any questions?
Sure. Any questions?
So this was her physical exam from
So
the
this-
ED?
So this was her physical exam from the next morning. So she was admitted from clinic to, well, she went from clinic to ER, and then from ER admitted overnight to clinic.
Gotcha.
So this was her exam.
So technically, at this time when she was being evaluated, she was having the chest pain?
Yeah, she was having a chest pain at this time. So in the ED, they didn't, from her ED records, the only thing that I was told was that she came in for shortness of breath and lower extremity edema, but no chest pain at that time.
She didn't have edema on the exam?
No. No, my son didn't have it.
Those are good fellows.
Essentially, it's like a normal exam. But
Yeah.
this is from the chart, right? I mean, or did you
I saw her
examine
this
Oh,
morning,
okay.
she didn't have any
Oh.
edema.
Okay. Wow.
Yeah.
I'm just surprised because she has gained, 10 pounds over,
So this
I don't
was,
know, a month. And
Yeah.
I'm surprised that she doesn't have any really evidence of that.
Did they diaries her heart or something?
they did give her Lasix in the ER. She
Oh,
took it as
okay.
something wrong with Lasix. Okay. So this was her lab when she came in. So her CBC from the 30th, June 30th, her white count went from 11 to 9, and hemoglobin was stable from June to July 1st at 11. Hematocrit was 37 and 34. Neutrophil count percent was high on when she got admitted. On her chemistry, nothing major on her chemistry, but her cardiac enzymes, her troponin, the first time was negative, and also the second time was also negative. And her BMP when she came in was 319. And then on the July 1st, she had increased to 609, even though she received, she received Lasix.
Did you say what her EKG found? I'm sorry, I probably missed it.
So that was also part of the whole, of the reason I'm presenting it.
Oh, okay.
Probably slide into the last.
Okay, any other questions? And this was who you were. So her chest X-ray did show some central pulmonary vascularity that was mildly common. So any diagnosis for what we think?
Even though we know the name of the topic, I don't think that would have been the first thing that
I
would
know.
come to my mind
Yeah.
for sure.
Well, I mean, if you didn't know the topic, then what would be the differential diagnosis for this patient?
I'm sorry, go back. What did her chest X-ray show? You said just now. Cardiomegaly stable. Okay. Well, I mean, I was just, well, maybe I should let the fellows talk. before-
Right.
Yeah, okay.
No, I think I'm like, should
I'm
I
like,
say
well, I was about to just spew a bunch of stuff, but I'll be quiet for a little bit.
If I were admitting her, given the fact that she had evidence of an acute coronary picture at that time, I would be concerned that there was some exacerbation of her previous admission that, led to reinfarction or sequelae of that initial infarction. She may have ruptured something that was making her heart failure, even more robust. The fact that she didn't have lower extremity edema is confounding, but I don't think that would have prevented me from going down the heart failure pathway and really working her up for a new MI. Yeah, and like Dr. Espinosa said, the fact that we know the title, I wouldn't have looked for that, given that it's not very common, unless she fit all my textbook criteria of who Takotsubo presents in. From what you've said so far, she doesn't.
Is anyone thinking PE?
Yeah.
She has a history of PE, she's
Recent surgery.
right.
Yeah.
It's kind of what I'm thinking about, not ACS, because of their history of PE.
Got from Houston and San Antonio somehow, or either in a plane ride or a bus ride or car trip.
I think you kind of have to think about aortic dissection with this kind of chest pain picture and
Distress and
distress, yeah, and no real evidence of edema, so yeah. I mean, I think that's one of the things you want to for sure consider, because if that's going on, that's not good. I mean, but given her history of COPD, I don't think this is likely, but you would want to sort of think about COPD-related things, exacerbation, pneumonia, even though it's just X-ray. But I mean, I think that would sort of be probably lower down, but on the differential too. Oh, wait, go back. I did not really get, I need to read that better, sorry. Vasospasm, yeah, I didn't think about that one. Pericarditis, yeah, that's a good one.
So this lady, actually when her history was sounding very much like an anxiety attack. Because the nurses reported overnight she was sort of going back and forth, and when you see her, she's like really looks stressing out a lot. So one of the things that that came to mind was, of course, acute coronary, but she also looked like she was having a panic attack. So the reason why I showed this EKG was because when she was admitted, even though whoever was on call, the physician that was on call ordered the EKG wasn't done that night actually. and was delayed until later in the morning. So that's why when we saw this, we panicked. So we saw it. So, can anyone tell me what you see on this EKG? Is anyone willing to volunteer?
I already talked him off the hook. All right, so she's got downsloping T waves. She has a depression of the ST segment as well as those downturned T waves. I don't see, this is one that looks strange enough that I would turn around and flip over and look for right-sided infarction on that. Get it. I'm not seeing that. But yeah, I would be worried about a repeat infarction. She doesn't have any criteria that I can see for PE, the Q prime, the element of P. Mnemonic.
So when we saw this EKG, also we were concerned, like I said. So she has a T-wave inversion with 2-3 and AVF, and also B3, B4, 1, and AVL also. So we called cardiology. The interesting thing though was that her chest pain got better after she received anxiolytics. So this EKG was done after she got the anxiolytics. Her chest pain resolved, and this EKG was done after. So the T waves are not as prominent as they were in the previous EKG. And this TTE was actually done in the morning, before I saw her actually. So it showed an EF of 55 to 60%, mild concentric LVH, wall motion LV, systolic function that are normal. Like I said, LVF 55 to 60%, and moderate diastolic dysfunction. Aorta is mildly thickened, otherwise normal, mild AR and PR, trace MR. So this was our differential diagnosis. Cardiology came to, at this time was there, and she was started on aspirin and Lovenox. And also we got records from the previous hospital that she was seen for the left heart cath. So the medical records at that time from the outside hospital in Houston showed that she had a left heart cath that was done due to evidence of ST elevation MI, and her EF was 25% at that time, which had normal coronary arteries. But her left ventriculogram that was done was significant for severe apical ballooning that was consistent with Takotsubo cardiomyopathy. So while the initial impression was for unstable angina versus not ST elevation MI, her presentation was thought to be consistent with Takotsubo cardiomyopathy. And cardiology recommendation was to control the patient's anxiety with anxiolytics, also to increase the core reg that she was already on from 3.125 to 6.25. So that was. And she was kept in her center. So this is an EKG.
Oh, okay, sorry.
So this was the first EKG that was done in the morning when she was complaining of chest pain. So it shows T-wave inversions. And then the repeat EKG after, I said her chest pain went away after she got anxiolytics. And this was the repeat EKG. It shows not as common T-wave inversions. And when we obtained records from the hospital in Houston, where she had her left heart cath, it showed that she had a left ventricle, or she had a left ventricular that was significant for severe apical ballooning that was consistent with cardiomyopathy. and cardiology recommended putting her on anxiolytics because she was already on, and to increase her COREC from 3.125 to 6.25 to control catecholamine surge during anxiety. And to lisinopril, but she was becoming bradycardic, so we went back to COREC 3.125 and continued to lisinopril 2.5 milligrams. So, I guess there's no surprise, it's Takotsubo cardiomyopathy. So this was what the patient had. So this cardiomyopathy is named after similarity between the left ventricle and the Japanese octopus trap that has a wide base and a narrow neck. And it's called, it can also be called reversible LV dysfunction, broken heart syndrome, stress cardiomyopathy, transient LV equiballooning syndrome, or ampular cardiomyopathy. And the prevalence is about 1 to 3% of patients, and the majority of the people are women aged greater than 50 years old. So it's hypothesized that a lack of estrogen is what predisposes elderly women to the cardiomyopathy. The pathophysiology is not very well understood, but there's thoughts of vasospasm, dysfunction of the microcirculation, left ventricular outflow tract obstruction, and catecholamine overload causing the cardiomyopathy. And precipitating factors usually is sudden emotional stress or physical stress. This lady was just a very stressful lady.
She didn't have any particular event though?
She didn't have any particular event, no specific event that triggered this for her. But when you see her, she just looks,
Generally
it's very anxious.
She's vibrating at a high
They
level.
worried about her daughter not coming, just different things.
And she wasn't having any chest pain when she was sent from the clinic to the emergency room?
From
And she
the
did have
notes,
chest
from the
pain in
notes,
the clinic.
no.
I
Okay.
thought the clinic note said she was clenching her chest.
No, this was, the HPI was when she was sitting in the morning. So when she was sitting that morning, she was complaining her chest.
So she was seen in clinic, looked like she had kind of exacerbation of heart failure going
Yes.
on. They sent her in for diuresis, and it's just like that spiral up of, oh my gosh, I'm getting admitted now, probably.
Could be.
It'd do it for me if I was 78.
Yeah. So this is a possible pathophysiology of how stress can cause the myopathy. So mental stress or physical stress causes a catecholamine surge. So the norepinephrines act on the beta receptors on the heart, and they cause impaired myocardial perfusion, myocyte injury, and LVOT. So the most common presenting clinical symptoms are chest pain and dyspnea, which the patient had. Uncommon presenting symptoms include syncope, palpitations, hypotension, cardiogenic shock, nausea, vomiting, some ventricular arrhythmias, and cardiac arrest. And the cardiac biomarkers that you find are elevation in troponin. The elevation in troponin is not as high as with acute coronary syndromes. And also you can also have an elevation in the BNP, and the BNP elevation is usually higher than that seen with CHF investigation. And the most common ECG abnormalities and ST elevation, usually the procordial leads and T-wave inversions. And there is a Mayo Clinic criteria, and it's unobstructed coronaries on angiography, modified transient wall motion abnormality on an echo with or without apical involvement. And this abnormality has to extend beyond a single coronary territory. And new ECG changes of troponin rise and absence of myocarditis and preacillative coma. And all four criteria has to be met before you can diagnose someone with this cardiomyopathy. So when there's unobstructed coronaries on angiography, it should be followed by a left ventriculogram to ensure that the diagnosis of this myopathy is diagnosed. So this picture is sort of hard to to get a hold of what the cardiomyopathy looks like. So I think this picture is a little better. This is a cardiac CT angiography that shows left ventricular apical hypokinesis with the ballooning of the apical segment of the ventricle. So this is diastole and this is systole. So you can see how the apical region is ballooned, and that's how the diagnosis of the cardiomyopathy. Treatment for this cardiomyopathy, ACE inhibitors and beta blockers, and there are no clear guidelines as to how long the beta blockers and ACE should be used. And also anxiolytics to control emotional stress. And the prognosis of this myopathy is usually good because most people have a rapid improvement of their LV systolic function in a period of days, 2 weeks. And in her case, her echo, or her left ventriculogram showed an EF of 25%, and the TTE that was done this visit showed an EF of 50 to 55%. So she had a return to normal systolic function. So I guess the question is, what could we have done differently in this lady's case? Is there anything that we could have done?
Get records faster.
Yeah. So if she had showed up to her post-discharge visit with a copy of her discharge summary,
Yeah.
you know, it obviously would have been really helpful.
Yeah.
And close the loop.
And even though when she presented she wasn't complaining of chest pain, an ECG was ordered and it should have been done immediately at that time. It probably would have been normal because she wasn't having chest pain initially when she presented in the ER. But when we saw her that morning, she was complaining of chest pain, and it was good that of course, if someone has chest pain, you have to release EKG.
And did she ever get a CT chest, or did they roll out
So she never had a CT chest. She never had a CT chest. Her SATs were usually in the 90s, 94s, under 2 liters, and she was on 2 liters of oxygen at home. So really, that's the thing. So I guess there's nothing really we could have done, besides getting the records, like you said. Could we have ruled out ACS sooner with her? You can't really tell the difference between ACS versus this cardiomyopathy. The main thing to do, if we were considering this as an ACS, was to get a cardiac cath on her. And that's the main diagnosis for this cardiomyopathy, because you can't just assume that it's cardiomyopathy. And elevation of cardiac troponin is usually reported in most of the cases, as I said before. And extreme elevation of BNP that is out of proportion to increase in troponin could be a useful additional diagnostic tool to distinguish this cardiomyopathy from STEMI. But again, like I said, you have to do that because you can't just assume that this is it.
I wonder if troponin was drawn.
But troponins were normal. When
But they were drawn in the ER.
But that was an
6 hours
ER.
Before she had the
Yes,
chest
before she
pain.
had the chest.
That's interesting.
And that's it.
I have a question.
Yes.
Because I had some exposure in a third world country, hospital management, and in the old days, before the age of beta blockers or the ACE inhibitors, they used to treat in Southeast Asia, like somebody coming with chest pains or UMI, just like Valium or anxiolytics, and let them stay and convalesce in the hospital for days or weeks. So I was just wondering whether or not, in this case, would Valium alone or some anxiolytics alone would have helped this patient at all in the absence of any other medication in the very resource-poor countries presenting with this kind of case.
Well,
And at that point, I mean, if we don't have any access to cognitive care facilities, what would we have done differently? Because they both present very similar, like ACS and Takotsubo at that point. So, is there any studies or anything that you know of that?
I mean, if we don't have any access to anything,
Right.
we give her the anxiolytic and it's also chest pain, thank God. But if it's not, but if it's an ACS, then no.
I mean,
Yeah.
what I'm trying to get at is there any cases where they have a true ACS cases and somebody gave them Ativan or Valiant, and would that help with the chest pain if somebody has acute coronary syndrome?
I'm not sure I would, because you have an obstruction of the coronary that's causing ischemia. I'm not sure it would.
No?
I mean, morphine potentially.
I was gonna say morphine to relieve
Morphine.
pain, so that you don't have a catecholamine surge to
Right,
Yeah.
right.
drive for the cardiac damage, but I don't know.
Pain relieving and anxiolytic at the same time.
Yeah.
That would be the third world alternative to integrate the CAP
And CAP?
and stents.
Did the other hospital have a plan for managing her anxiety?
So she came in with some anxiety medication. She already had Xanax. She was taking Xanax 3 times a day. Well, 2 times a day. We upped it to 3.
That's a good choice. She was on mirtazapine.
And she was also on Remeron too. But the plan was to send her, well, we needed to increase her, or change her medication, because she was her anxiety was obviously not still with the medications that she was on.
Actually, speaking of the morphine, I seem to, I mean, it does have some direct effect on the heart, like reduce demands. Because I seem to remember your algorithm,
Right.
intern year, you do the nitro, that doesn't work, you do a little morphine. I don't know, so there's some, so anyway, I'm sorry, I'm obsessing on that, but I think morphine more, of course, more than benzo, but there is some potentially like decreased load on the heart with morphine. So anyway.
It's also vasodilator.
It's a bit, there you go. Okay, I couldn't remember the physiologic reason behind why we use it. Okay, it's a vasodilator. There you go.
The other question I have is that, so they're using Xanax or a short-acting benzo to control her anxiety. Is there any thought of like kind of moving her to a longer-acting?
We put her on TID instead of the DID, but yeah, that was better.
So the problem with the short-actings is you can get rebound anxiety when it kind of reaches peak and it starts to wear off. The person can become more anxious at that point. And for somebody who seems to have a pretty bad anxiety disorder,
Yeah, and so what hospital was she seen in? It was in the VA? No.
You mean for this admission? She was in a Christus Center.
Oh, okay. Well, I was just thinking, like this is someone who probably could benefit from like psychotherapy, psychologist support, counseling. Sounds like she probably has like generalized anxiety with spurts of near panic attacks and stuff. So anyway, so it would be good to find that type of services. At the VA, we do have that, but I don't know about like in the community. That might be hard to find.
you know anything about the chronicity of her anxiety disorder? Because the other thing is you start thinking if she has like kind of a new onset anxiety disorder in a late life, you start thinking, well, is she demented? Is, what, kind of, is there been sort of life event, that could be precipitant for it?
And I don't know, from the history, I know she's been anxious. She's just she has generalized anxiety disorder, bouts of panic, frequent panic attacks. And she's staying with her daughter, and she's pretty, requires for the daughter to be there all the time because she's always anxious, always in distress. But I'm not sure how long she's had the anxiety disorder. And she does have Alzheimer's dementia.
Well, I was gonna say, that's a good point, is that she wasn't really on it, and I don't know what stage she was at, and, you know, she would have been a candidate for medication or some other intervention, but she sort of has a chart diagnosis of dementia, but we don't really know. Is that a delirium? You know, was that based on the delirium episode, was that based on mild cognitive impairment, was that based on somebody's formal assessment?
So potentially, I don't know if she was on an SSRI, but that
No, she was on
might
one.
be something, you know, try.
And I know you said she doesn't fit, to me, she seems like a really typical Takotsubo patient, an older woman, with sort of anxious phenotype. But what I guess is missing is the critical event. So, I mean, I've had several patients in my practice, and it's usually death of spouse or child, or relocation from, you know, some other part of the country to San Antonio to live with family that's really stressful that triggers. And then in one patient, it was a cancer diagnosis.
So you've seen this?
Mhm.
I have never seen this before.
So-
I've heard of it, never seen it, so that's awesome. I
My,
didn't know.
my curiosity with her though is that she's had several cardiac caths per your report of her history,
One.
which
One.
may or may not have been the first event of this Takotsubo's, because it is a recurrent thing for some people. Once you get it once, you can get it again and again. So I wonder if she's just anxious lady with Takotsubo, broken heart, and this is her second evaluation for it. We just missed it the first time.
What's the mortality on this if she has no access to healthcare?
So the mortality is pretty low. It's 1 to 3% actually.
Okay.
Yeah.
We'll kill her evaluating her for this.
Mhm.
Right,
Yeah,
that's what I mean.
Yeah, if she'd gotten a second cath, that would have been.
Right. That's all I
It's a
know.
good learning case.
What's the benefit versus risk of
Definitely.
aggressive working up?
Since you saw the patient, I just was curious, based on the, if I remember right, the patient's weight was like 44 kilos, so didn't have a BMI, but sounded like a fairly thin, not really
Yeah, she's
obese
skinny,
patient.
yeah, she's skinny,
Yeah,
yeah.
so does it happen like a more certain, like obese patient, or is this anybody?
Oh,
Have
yeah.
you said you have
Risk
seen
factor.
several with the Takotsubo?
She's seen several.
Yeah.
I've seen one or two, and they typically are thinner people.
Are they?
I believe in Nigeria,
Everybody get a chance to sign in?
Nigeria for dream, the nation of God, in unity we stand,
Graded my licensing birth.
building a nation in unity. I believe in Nigeria, Nigeria for dream. I believe in Nigeria, Nigeria for dream, the nation of God, in unity we stand, building our nation in unity. I